Thank you, Carolyn. I'm going to have Janine advance my slides. And I'm hoping to open up some discussion. This may be something that your unit has complete consensus on, but I want to open up some topics at least to consider in reducing contamination. Hopefully, at some point, discuss the flip side, and that is optimizing the retrieval um, of a pathogen if the patient actually does have a pathogen in their bloodstream. So next slide. So if you look at the literature on blood culture contamination and just guidelines in general, it's very difficult to find a consensus statement or a practice guideline. I found this practice guideline from the Emergency Nurses Association in 2012. It was very comprehensive, well referenced, and then they updated it in 2020. So the bulk of what I'm going to be sharing with you is from that particular practice guideline, and I can send that out for any of you that would like to read it in detail. But basically, just reiterating that we know what an important role cultures make in the diagnosis. Contamination is a common problem in the hospital setting. Rates of contamination are reported between 0.6 and 12.5%. The goal is to keep it under 3% and probably less than that. And we know if the blood culture is contaminated, it can lead to unnecessary antibiotic exposure, length of stay, cost, and harm. Next slide. So one of the articles that I could find that was neonatal specific was actually published a decade ago. This was a survey sent out to neonatologists through the AAP perinatal regions, and it simply asked basic questions of mostly neonatologists and fellows. I don't believe there were any nurses that were asked these questions, but the practice was pretty variable. And then there were areas where whoever was answering the survey actually didn't know what was happening in their unit. And I would encourage all of you non-nurses out there to find out what's happening in your unit, especially if you have concerns about the incidence of false positives or contaminants. Next slide. So what the guideline goes through, and again, this is from the Emergency Nurses Association, it goes through a variety of things and then gives the evidence to support what they recommend in their clinical practice guideline. Next slide. So they start out talking about standardizing of the procedure and the personnel. I'm going to talk about diversion a little bit more in a minute, and I'm glad to talk offline with you more about what is in the literature, but they were able to recommend a diversion of 1 to 2 mLs of blood before drawing a peripheral venipuncture. Use of a standardized procedure, sterile procedure, was also highly associated with reducing contamination. Obviously, providing education and training for the people who are going to collect blood cultures is supported with a reduction in contamination, and then monitoring contamination rates, and then providing performance feedback to those individuals who drew the cultures. It's one of the questions that we put together that actually didn't go out, but I would encourage you to find out if you have contamination rates monitored by your microbiology report, and if you actually receive those reports and are able to review them. Next slide. In terms of skin prep, products containing alcohol have the highest level of evidence in terms of reducing contamination. Over time, there's been more and more use of chlorhexidine, even in less than 2-month-olds, but still the evidence strongly supports the use of an alcohol-containing product in children under 2 months of age. It also recommends, and again, this is one that's difficult for neonatal population, a 30-second vigorous rubbing back and forth prior to the venipuncture, and then allowing the agent to dry. Next slide. In terms of collection packs and bottle prep, there's clear evidence that putting together supplies in a single spot for the person who's going to be obtaining the sample has been shown to reduce contamination. I think this is a very similar to the line trays or the line carts that have been put together in the last decade or so. And then the tops There's been research on whether the tops need to be alcoholed prior to inoculation, but the fact is that the manufacturers recommend it, as do the Clinical Laboratory Standards Institute. So hopefully this isn't a debate in your facility, and these membranes get alcoholed and allowed to dry prior to inoculation. Next slide. So specimen diversion, just a moment about that. So the theory is that there's a potential for a microscopic skin fragment to be contained, to have bacteria in it, and more common if a large bore needle is used. So the concern is that in venipuncture, there can be a contaminant from the skin and not actually represent an infection in the patient. And since this 2012 guideline was published, there's been two more studies, one in 2017 and one in 2020, again, supporting the use of diversion in emergency department patients, in and out patients, by simply taking 1 to 2 mLs of blood and diverting it into a sterile container prior to drawing the venipuncture sample. And I know if there's a nurse listening about, we really got 1 to 2 mils to divert, but there's practical ways to do this if it's something that you're interested in your own unit. Next slide. Collection from intravenous catheters remains problematic because we know that these catheters can become colonized, the hubs as well as the claves that are attached. There's been an old study that showed there was no difference in contamination rates from a freshly inserted IV and a peripheral sample. But I think this is far from clear, and I'm guessing the practice remains variable in your own facilities and probably is worth some discussion. The conclusion of this practice guideline is that using an IV to draw a blood culture should remain an option in the patient populations where getting a sample, an adequate sample, are difficult, which certainly is neonatology, hem-oncology, and critical care. Next slide. So I think the recommendations are to standardize procedure. As with many of the things that we practice in neonatology, once you've taken a look at it, standardized it, and make sure that people know what the standard is, you're probably going to improve practice. Talking about whether or not a vascular device should be used or venipuncture should be the standard is a discussion that has to occur, because we know that sometimes timeliness and the ability to get an adequate volume can't always be facilitated by a venipuncture. So I think these are items that need to be discussed on a case-by-case basis, and I would be curious to know if you have a unit standard about preferred site, if that's ordered in the order for a blood culture, and then how do you deal with it if the nurse can't get the sample in the manner that you've ordered it. I think skin prep is something that is important. I know that chloropreps have recently been recalled because of a contamination, and one of the nurses that Curlin works with was saying they were concerned about running out of supplies because of what they have currently. But I do think that with delayed bathing in many of our units now, especially in the bigger, more mature babies, we probably got skin that's a little more heavily colonized than we used to see, and maybe that needs to be addressed in terms of additional cleaning of the site prior to obtaining the sample. Friction and alcohol, we know, can lead to skin injury in our very low birth weight babies, so I think that's a recommendation that needs to be modified, specifically in the very low birth weight patient, but certainly should be discussed if venipuncture is going to be the standard. And then I do think that unit-based procedures ideally should address all the NICU variables that are very different from a generic procedure that you might get out of a journal like Lippincott, or a program like Lippincott, which has standardized procedures, but really don't address many of the NICU issues. And then I do think, even though two-person draw is not addressed in the standard that I talked about today, I think that many of you are aware that if you've got a a baby that's moving, that having a second individual is going to reduce the risk of contamination during the process. And then I think that personally, that this is an important enough procedure that ideally um, it is a competency that is included in new hire orientation and then reviewed on an annual basis, because there's an enormous amount at stake to have this procedure accurately represent what's happening in the patient, not lead to false positives and contamination, and potentially prolong antibiotic exposure.